Hello students, this is Dr. Sucratha John, Assistant Professor to Department of Oral and Maxillofacial Surgery, Vinayaka Missions, Shankaracharya Dental College. So today we will discuss on the topic of osteomyelitis of the jaws. So by definition, if you see, the osteomyelitis is defined as an inflammatory condition of the bone which begins as an infection of the medullary cavity and Haversian systems, and it extends to involve the periosteum of the affected area. So in simple terms, it means that it's the inflammation of the bone and the bone marrow. So if we split the title of the disease, that is osteomyelitis, it means osteo, which means bone, myelos, which means marrow, and itis, which means inflammation. So osteomyelitis in together means the inflammation of the bone and the bone marrow. Now let us look at what are the etiology of this osteomyelitis. So there are various etiologies have been enumerated. So this include either it could be the most commonly seen etiology, that is the odontogenic infections, any infections which is pertaining to the tooth or starting from the tooth. Or it could be some local traumatic injuries, it could be some peritonsillar or nearby soft tissue abscesses which is extending into the bone and causing the osteomyelitis, or it could be some other local infections, or if any compound fracture or anything occurred in our jaw, especially the mandible, then also it can progress to the osteomyelitis. Now when we look upon the pathogenesis of the osteomyelitis, so when we see if it is most commonly it is the case of it is a sequelae to the dental caries. So when we see the dental caries, the untreated dental caries can progress and lead to the periapical inflammation. So the untreated dental caries leading to a periapical inflammation, and if that is also untreated, that is untreated periapical inflammation progressing to another conditions. So it could either develop into a periapical granuloma or a periapical cyst. So if it is also untreated, it can either cause to or it can lead to other sequelae. So as we see the flow chart, so the pulpitis, it could be acute or chronic, is untreated case leading to apical periodontitis, leading to either periapical abscess or a periapical granuloma, which in untreated condition can even end up as a periapical cyst. This again can progress and develop and cause a osteomyelitis. Again, there are different types of osteomyelitis, so it all depends on the what is the etiology. So most common or most seen etiology is the odontogenic infections, which is again causing the osteomyelitis. And when we see the microbiology, what are the organisms which are associated with this development of the disease, that is osteomyelitis of the jaws? The most common culprit is the Staphylococcus aureus, which is the principal cause in virtually all categories and in all age groups. So we have to remember the first or the main culprit is the Staphylococcus aureus, which is followed by the beta hemolytic streptococci. So first one is Staph aureus, which can followed by the beta hemolytic streptococci, and there can be other organisms also. So we have seen the etiology, we have seen the microorganisms involved. Now we will just summarize on what are the predisposing factors, which all factors can put one or one patient in a risk factor of developing the condition of osteomyelitis of the jaws. So it could be some conditions which affect or which alter the host defense mechanism, or it could be some conditions which alter the vascularity of the bone of the subject or the patient, or it could be some factors which can affect the virulence of the organisms. So we will look into each of these things one by one. So what are the conditions which can affect the vascularity of the bone? So this could be either a therapeutic irradiation, or some conditions like osteoporosis, Paget's disease, or fibrous dysplasia, or some bone malignancies. All these diseases can affect the vascularity of the bone. As we know already, the mandible, if you are talking about the mandible, it is already supplied by the main blood vessel, which is the inferior alveolar vascular thing, also along with that periosteal supply. So if anything or any causes which are limiting or which are reducing the blood supply to the bone, especially the mandible, it can also end up in patient developing the osteomyelitis. So first condition could be the conditions which alter the host defense mechanism. So some other chronic debilitating systemic diseases like the diabetes mellitus, agranulocytosis, leukemia, severe anemia, malnutrition, drug abuse, chronic alcoholism, sickle cell disease, all these diseases can put the patient at a higher risk of developing a osteomyelitis. So the predisposing factors, first one include the conditions which alter the host defense mechanisms, or it could be some conditions which affect the vascularity of the bone, or it could be some conditions which are related to the virulence of the microorganism itself. That is, some organism precipitates some thrombi formation by virtue of their destructive lysosomal enzymes. So, as we see, it is by the virulence nature of the organism itself is putting us or the patient at a higher risk of developing the osteomyelitis of the jaws. Now, let us move on to the classification of the osteomyelitis. So, there are numerous classifications which are given in time to time from the historic times for the classification of the osteomyelitis. The main ones include, or the main which is the mostly followed is the general classification, which classifies the osteomyelitis of the jaws into the suppurative osteomyelitis and non-suppurative osteomyelitis. So, the main two categories include the suppurative osteomyelitis and the non-suppurative osteomyelitis. The suppurative osteomyelitis, again it has other three categories which include the acute suppurative osteomyelitis, the chronic suppurative osteomyelitis and infantile osteomyelitis, in which the chronic suppurative osteomyelitis again has the primary and the secondary variants in it. So, these were the suppurative osteomyelitis, which has the acute one, chronic one and the infantile one. Then when we move on to the category of the non-suppurative osteomyelitis, again we have different types of osteomyelitis in this category also, that is the non-suppurative osteomyelitis. This includes the chronic sclerosing osteomyelitis, Garre's sclerosing osteomyelitis, actinomycotic osteomyelitis, radiation osteomyelitis and the specific infective osteomyelitis. That is some specific infections which can cause the osteomyelitis like tuberculosis and the syphilis. So, main in the classification we have suppurative and the non-suppurative osteomyelitis. Suppurative had the three varieties mainly, the acute, the chronic and the infantile. The non-suppurative osteomyelitis, again we have the chronic sclerosing osteomyelitis, the Garre's osteomyelitis, actinomycotic, radiation and the other specific infective osteomyelitis. Now, we will look into all of these categories, each one by one. Now, moving on to the diagnosis. So, the osteomyelitis of the jaw has been proved as challenging condition to diagnose, treat and cure. Why? Because first of all, when it starts as when the osteomyelitis disease is occurring in the starting or the initial stages, the patient will have pain or other symptoms which is actually experienced by the patient as some vague symptoms. It is not a specific symptom, like patient will not be able to point out to the clinician or to the operating surgeon or to the doctor like which area is painful or which area is hurting properly. So, it is a dull or deep gnawing and a vague pain or vague symptoms in which patient itself is confused only. So, in this case it is challenging for the clinician, challenging for the physician to diagnose such a case of the osteomyelitis. So, the final diagnosis should be based on the following parameters. So, first we should take a proper history of the patient, what is the clinical presentation, that is proper oral examination, intraoral examination and the extraoral examination, which is again supplemented or supported by the imaging techniques. And in case of osteomyelitis, especially if it is a chronic case, post discharge everything is there, then obviously we have to go for a culture, which is to be followed by a histologic analysis, that is the biopsies. So, when we diagnose a case, first is depending upon the history, the clinical presentation which is added upon or supported by the imaging techniques, the pus culture and the biopsies or the histologic analysis. What are the imaging techniques? So, when the patient comes or with the chief complaint of patient having a vague pain or maybe some odontogenic source is there or some trauma history, anything is there, then when we take the history, we are suspecting an osteomyelitis case, then we can go for imaging techniques. Like different techniques are there, it could be conventional radiographs, like the patient is able to point out or tell us symptoms relating to a separate region, then we can ask for a conventional radiographs like an IOPA or RVG. But again, if the symptoms is vague and the patient is having a long history, then we have to go for an OPG. Otherwise, we can go for a CT scan, the PET scans, laser Doppler flowmetry, nuclear scans and other immunologic workup. So, main ones, first we have to start with the base ones, which are the conventional radiographs supplemented by the CT scans and other imaging modalities. Now, let us discuss about the different types of osteomyelitis. We look into the main ones and what are the main symptoms or main points which are to be discussed. First one is when we read about the classification, it was the suppurative and the non-suppurative osteomyelitis. In the suppurative wing or the suppurative osteomyelitis, in that classification we had again the acute suppurative osteomyelitis, chronic suppurative osteomyelitis and the infantile osteomyelitis. So, let us discuss about the first one, that is the acute suppurative osteomyelitis. So, as the name itself indicates, it is an acute case. So, it is a sequelae of a periapical infection that often results in a diffuse spread of infection throughout the medullary spaces with subsequent necrosis of a variable amount of bone. So this acute condition, usually it is occurring as a sequelae to a odontogenic infection and spreading through the marrow spaces, leading to subsequent necrosis. It may involve maxilla or mandible and usually common in the infants. In maxilla, it is fairly well localized, whereas in mandible, it tends to be more diffuse and vague. So when we talk about the organisms, again the Staphylococcus aureus or pyogenes is most commonly found, but also spirochetes and gram-negative bacteria also can be found. So it's a mixed infection. So first it can start with an aerobic organism. As the disease progresses, then the pus or any infections that develops through the course of the disease, again the mixed flora can be cultured from the pathologic area. Clinical features, as we are talking about acute suppurative osteomyelitis, again there will be all the constitutional features which are usually seen in an infection. So patient can experience a severe pain, malaise, fever, regional lymphadenopathy, elevated WBC counts, teeth involved in the region may become loose and sore, paresthesia or anesthesia of the lip, trismus may be present, and also pus may exudate from the gingival margin. So all the constitutional features along with the localized features. So when we look upon the radiographic features, especially after sufficient bone resorption, irregular moth-eaten areas of radiolucencies may appear. So when we think about the radiographic picture of osteomyelitis, the first word which should come to our mind should be the moth-eaten appearance, moth-eaten appearance. So again we have to keep the thing in our mind that it cannot be easily readily appreciated in an acute case or in the starting stages of the disease. As the disease progresses and it goes towards a chronic course, then only we will be able to see the moth-eaten pattern of which is specific to this osteomyelitis of the jaws. Now we move on to the chronic osteomyelitis, which is again the chronic suppurative osteomyelitis. So this again has two varieties, either the primary chronic osteomyelitis or a secondary chronic osteomyelitis. Primary chronic osteomyelitis meaning it is resulting from a relatively less virulent organism. So it is here the organism involved in this chronic suppurative osteomyelitis, the primary one is an organism which is less virulent strain. That means it is starting as a mild inflammation and it is running a long course. Second one is the category which is the secondary chronic osteomyelitis. This is occurring after the acute phase when treatment did not succeed in eliminating the infection. That is, when the patient has already presented to us, we have diagnosed the case also and we started the medications and the treatment, but still the patient is not recovering from the medication or the disease is still progressing. In that case, we will label it as a chronic secondary suppurative osteomyelitis. So we have two varieties, the primary one which is starting with a less virulent organism, or the secondary one in which that started as an acute one in which the patient did not show any improvement with our treatment, then they are passing on to a secondary osteomyelitis. So clinical features of this chronic suppurative osteomyelitis. So here how to differentiate between an acute case of osteomyelitis and a chronic osteomyelitis. So acute osteomyelitis usually has a short course as the name suggests, while the chronic one has a long course. So the arbitrary time limit to differentiate the chronic from an acute osteomyelitis is 3 to 4 weeks. So any symptoms of osteomyelitis which is persisting more than 3 or 4 weeks course, then we will label it as a chronic suppurative osteomyelitis. So here the patient experiences a dull aching pain and minimal tenderness. Also, non-healing bony and overlying soft tissue wounds with induration can be seen in the oral examination. So which is not seen in the acute osteomyelitis cases. The intraoral or extraoral some draining fistulae will be seen. Why? Because the disease is running a chronic course again. So there will be the inflammation which is now progressing towards an infection, the bone necrosis occurring, all the pus and all the amount of fluid developing. Now the pus has to escape from the marrow spaces to outwards through some path. So it is the pus and everything, that collection is trying to exit the bone through some areas which is known as a sinus or the fistulae which are developing, so that the pus can be relieved or it can be drained outwards. So intraoral or extraoral draining fistulae can be seen in case of a chronic suppurative osteomyelitis. Then when we palpate the bone, a thickened or wooden character of the bone or lifeless appearance or of the bone can be appreciated. Then enlargement of bone due to new bone deposition. Since it is a chronic case, along with the destruction, some development of or enlargement of the bone due to bone deposition is also seen. So one side there is resorption is occurring and one side deposition is also occurring. Then loose and sensitive teeth can also be appreciated. When we look on to the radiographic features of this chronic suppurative osteomyelitis, here we can expect some radiographic changes because it is a chronic case. So in acute osteomyelitis initial stages, we may not be able to see the proper radiographic features, but in case of a chronic osteomyelitis, now since already 3 to 4 weeks have passed since the patient has developed the infection, now we will be able to see some changes in the radiograph. So now we can clearly label it as a moth-eaten appearance. So radiographic changes occurs only 3 weeks after initiation of the osteomyelitis process. It is generally accepted that 30 to 60% of the mineralized portions of the bone must be destroyed before significant radiographic changes are noted. So this we already know. For a radiograph to pick up the information of regarding to bone loss, then at least 30 to 60% of the mineralized portion of the bone should be destroyed, then only it will be showed as a radiolucency in the radiographs. Now in the early stage, there is widening of the marrow spaces and enlargement of the Volkmann's canals, which imparts a mottled appearance. So all these things together can lead to a moth-eaten appearance. So there will be mixed areas of the healthy bone and the pathological bone. So it is actually a mix of healthy bone and the pathological bone, along with the Volkmann's canal and the marrow spaces all enlarged. So the full or the normal bony architecture which is expected in a bone marrow and the cortical bone, that will become little bit altered, which can be appreciated in the radiograph as a moth-eaten appearance or a mottled appearance. Now what is the management? So it's a general management for we have to categorize what is the case. It could be a small lesions, extensive osteomyelitis or a persistent osteomyelitis case. In case of small lesions, we can do a local treatments like a curettage or removal of the necrotic bone and decortication. These are small procedures which we will discuss in the later slides. In extensive osteomyelitis, another procedures like decortication we have to do, along with, because it is extensive osteomyelitis, after we have removed the pathological tissue, some reconstruction also needs to be done. In persistent osteomyelitis, again large area of the bone is eaten up with the disease. We have to remove the full bone. Again we have to think about the reconstruction. Now we have finished with the suppurative osteomyelitis category, which includes the acute and the chronic and the infantile osteomyelitis. Now moving on to the second branch of the classification, that is the sclerosing or the non-suppurative osteomyelitis. The non-suppurative osteomyelitis, again it included many of the diseases, many of the types of the osteomyelitis. So let us discuss about the chronic sclerosing osteomyelitis. So the chronic sclerosing osteomyelitis, which is a non-suppurative osteomyelitis category only, it has again two different subtypes in it. It can be either focal sclerosing osteomyelitis or it could be a diffuse sclerosing osteomyelitis. Focal sclerosing osteomyelitis. So now we are talking about the non-suppurative osteomyelitis. First one is the chronic sclerosing osteomyelitis, in which we had two categories, which were the focal and the diffuse one. The focal sclerosing osteomyelitis has one more other name, which is known as the condensing osteitis. So we should be thorough with both these terms. So focal sclerosing osteomyelitis is also known as condensing osteitis. This condition usually is due to high tissue resistance or a low grade infection. So a combination of these two scenarios can end up or can lead to the patient developing a case of focal sclerosing osteomyelitis. That is, either the organism which is causing the osteomyelitis is of a low virulence type, that is a low grade infection, or the host or the subject, the patient, is having a high tissue resistance. So the combination of both the high tissue resistance along with a low grade infection microorganism, both can lead to the development of a focal sclerosing osteomyelitis. It is almost always seen in the young patients where the high tissue resistance or more reaction, body reaction is seen. Usually seen in the mandibular molar regions. Bone reaction, it is categorized as a bone reaction to a low grade periapical infection or unusually strong host defensive response. Here no expansion of the jaw is seen. This is a condensing osteitis or a focal sclerosing osteomyelitis. If we see the radiograph of such cases, when you can see that radiograph picture which I have already embedded in the slide. Here you can see there is a radiodense area near the root apices of the carious mandibular first molar. So that means some increased bony deposition is seen near the periapical region. So this condition is also known as a condensing osteitis. It has got the name condensing osteitis. Why? Because in that near the periapical region we can see like the bone has condensed to near the periapical region. So only it is named as a condensing osteitis, but actually it is a chronic sclerosing focal osteomyelitis. Now this category, whenever we see a category of this condensing osteitis, we have to differentiate this case from another entity, which is the benign cementoblastoma. So we have to differentiate a benign cementoblastoma from a condensing osteitis. Now how do we differentiate this? Since this is a condensing osteitis related to a pathology related to the bone, the pedial space or the periodontal ligament space will be seen properly as a space itself in this cases of the condensing osteitis. While in the cases of benign cementoblastoma, since the pathology is related to the tooth tissue itself, that is the cementum, which is a part, which cementum is the tissue which makes up the root portion of the tooth. So in benign cementoblastoma, it is seen as a tumor or an excessive growth of the cementum of the root of the tooth. So no pedial space will be seen between that pathology and the root. It is this pathology is in continuation with the root of the tooth. So in this way we can differentiate between the benign cementoblastoma and a condensing osteitis. So as we said, in condensing osteitis we can clearly or specifically see a pedial space between the tooth root and the bone. Here radiograph shows well circumscribed radio-opaque mass of sclerotic bone surrounding and extending below one or both the roots. So this is a case of chronic focal sclerosing osteomyelitis. Now what is the management? Elimination of the source of inflammation by extraction or endodontic treatment. So in most of the cases or all of the cases of osteomyelitis, mostly it is related to the, if it is related to the odontogenic any etiologies, then we have to take up the tooth for the treatment. Either we have to remove the tooth or we have to take up the tooth for an endodontic treatment. If the lesion persists and the periodontal membrane remains wide, re-evaluation of the endodontic therapy is considered. Now the second one, that is the diffuse sclerosing osteomyelitis. This is almost always similar to that of the focal sclerosing osteomyelitis, but as the name indicates, the difference between the focal and the diffuse varieties. So here proliferative reaction of bone to a low grade infection is seen. So here there is a proliferative reaction of the bone is there. Why such reaction is there? Also because the infection is of a low grade variety. It is more common seen in the older age group, especially in the edentulous mandible. On occasion there may be acute exacerbation and mild suppuration. Radiologically it mimics the Paget's disease, which has got the cotton wool appearance. So this cotton wool appearance, we all are familiar with this appearance. So this is specific mainly to the disease entity which is known as the Paget's disease. In Paget's disease, we usually see the cotton wool appearance, but a similar cotton wool appearance can be seen in another pathology, one type of osteomyelitis, which is known as the diffuse sclerosing osteomyelitis. So this type of osteomyelitis, it is a proliferative reaction of the bone to a low grade infection, usually seen in geriatric or older age group patients, usually seen in the edentulous jaws. There can be an acute exacerbation or a mild suppuration seen in this kind of osteomyelitis, and most commonly or most importantly we have to remember the radiographic picture can mimic that of a Paget's disease, that is a cotton wool appearance. So if you see in this radiograph, you can see this radiograph of the edentulous mandible. In this one specific region we can see a cotton wool type appearance, and that is then we have to suspect a case of this osteomyelitis. Management, again either the extraction of the tooth or the endodontic treatment of the tooth in question. Now the another entity, that is the chronic osteomyelitis with proliferative periosteitis, or commonly known as Garre's osteomyelitis. So now we were discussing about the second branch of the osteomyelitis, which is the non-suppurative osteomyelitis. In non-suppurative osteomyelitis, again we had the chronic sclerosing one, which can either be the focal or the diffuse ones. Now another 3 or 4 entities are again there, out of which the most commonly asked question is about the Garre's osteomyelitis, also known as the chronic osteomyelitis with proliferative periosteitis. So first we have to examine the name of the disease itself. If we split and see, that itself will answer what type of osteomyelitis it is. The Garre's osteomyelitis. It is a chronic osteomyelitis, the feature of this being a proliferative periosteitis. So what do you mean by the periostitis? So that is the inflammation of our periosteum of the bone. So the inflammation of the periosteum of the bone, also known as the periostitis. Here, what is the specialty? There is a proliferative periostitis. So proliferative meaning, again there is an exuberant growth is there. So chronic osteomyelitis with proliferative periostitis, also known as the Garre's osteomyelitis. Again, this is a non-suppurative type of osteomyelitis. It is a focal gross thickening of the periosteum of bone with peripheral reactive bone formation. Almost always in children or young adults, hyperplasia is located most commonly along the lower border of the mandible. Gross thickening of the periosteum of the bones and peripheral reactive bone formation resulting from mild irritation or infection. So this Garre's osteomyelitis, so this is inflammation of the periosteum, which is a proliferative in nature. So it could be caused either by an odontogenic infection or it could be some mild irritation or infections. Usually the age category belong to a young age or a children cases we see this type of osteomyelitis. Here hyperplasia is located in that area. So since it is a proliferative periostitis, there is excessive growth of bone at the particular region, at the region of irritation or inflammation. So here slight or lower border of the mandible, we may see some, or we may appreciate some change in the shape or a swelling or some change in the normal anatomy of the mandible can be seen. If you properly see this radiograph, in this we can see that a focal area of well calcified bone proliferation may be seen that is smooth and that often has a laminated or onion skin appearance. So when we see this radiograph, we can see that there is a layer-wise adhesion of the outer cortical bone is seen. So there is condensation of the cortical bone and overgrowth of bony tissue beneath the periosteum. So since the extra bony tissue is forming beneath the periosteum, because of this periostitis, again we can have a onion skin appearance. So earlier we discussed about a moth-eaten appearance, which is specific or which is common to all the suppurative osteomyelitis. Then we talked about a cotton wool appearance, which is usually seen in Paget's disease, but also can be seen in the other condition, which is the chronic focal sclerosing osteomyelitis. Now here we are discussing about a condition that is the onion skin appearance of the radiographic picture, which is specific to be seen in this Garre's osteomyelitis, because it is a hyperactive reactive osteomyelitis. Now what is the management part? Again, that is the removal of infected tooth, then we have to do curettage of the socket, then surgical recontouring. So in Garre's osteomyelitis, since there is the excessive amount of bone which is forming beneath the periosteum, if in untreated cases or chronic cases, then again we can appreciate a proper bone deformity or slight swelling or any change in the shape can be observed. So in these cases we need a surgical recontouring. This is attempted only if there is obvious expansion is there. For mild cases we won't do anything, but for a surgical recontouring is always indicated if there is an obvious bony expansion causing disfigurement. Otherwise we can take up for an endodontic therapy and antibiotics if signs of infection are present. But remember, this is a non-suppurative osteomyelitis, the Garre's osteomyelitis. Now what is the general management part for an osteomyelitis? First case, it is the conservative management. So when we will start with the conservative management. So that is for the initial or the starting cases. So we can advise the patient complete bed rest along with the supportive therapy, that is nutrition. Nutrition is very important already because the patient is undergoing some jaw osteomyelitis or some conditions or diseases. Again their oral intake can be lessened. So in this case we have to advise complete bed rest and patient should have a proper nutrition. Then blood transfusion if the patient is anemic. Then for the control of pain, again we can use analgesics, or if infection is there, antibiotics, then antimicrobial agents also. So when we look on to this antimicrobial therapy, so penicillins remain the time honored antibiotic of choice for the osteomyelitis. So mostly in starting stages all the aerobic organisms are all the main culprits involved in this osteomyelitis, the jaw osteomyelitis. So penicillins remains the time honored antibiotic of choice for this osteomyelitis. So the first choice is the penicillins. Initially gram stain guided empirical therapy is started usually with the penicillins. Then after obtaining the culture and sensitivity, then depending upon that report of this culture sensitivity, then we can start the specific therapy. So first we can start with the penicillins, then while we wait for the report of the pulse culture and sensitivity, then we can be able to appreciate what organism is there and that organism is sensitive to which antibiotic, and then we can narrow down our antimicrobial therapy to that specific drug. So that was the pharmacological management. Then the surgical management. So incisions are made intraorally or extraorally depending upon the location and also depending on the extent of the bone destruction and necrosis. In patients with compromised systemic conditions or toxemia, then surgical interference may be postponed for 2 to 3 days. So if the patient is already deteriorating in his systemic conditions, then first we have to stabilize that. Then along with that we have to do extraction of the loose or the offending tooth, the tooth in question. Then we have to take up the patient for a debridement. So following the incision and drainage, thorough debridement should be done and irrigation with hydrogen peroxide and saline should be done. That is proper cleaning of the area. So just the removal of the tooth will not solve the problem. So we have to take up that area, or we have to treat that area with a complete debridement. Then when we talk about osteomyelitis, again 2 terms we usually come across, that is the sequestrum and the involucrum. What is the sequestrum and involucrum? So first we will discuss about the sequestrum. So sequestrum is that piece of the dead bone that has become separated during the process of necrosis from normal or sound bone. This part of the bone is known as, or this piece of bone is known as the sequestrum. So it is a dead bone. So during the course of the osteomyelitis, the jaw osteomyelitis, the piece of bone which is already in the pathology, so that becomes necrosed and it will become, or it will start separating itself from the surrounding healthy bone. Now this part of the bone which is the dead bone is known as the sequestrum. Then what is involucrum? So small sections of the bone may be completely lysed, whereas larger ones may be isolated by a bed of granulation tissue encased in a sheath of new bone. So already we have discussed about the sequestrum. So surrounding the large sequestrum or these dead bones, there can be a bed of granulation tissue and which is encased in a sheath of a new bone. So new bone which is forming around an island of a sequestrum is known as the involucrum. So involucrum represents a thick sheath of periosteal new bone which is surrounding a sequestrum. So we can imagine like a sequestrum is a piece of dead bone and like an island it is there. So surrounding this island of this dead bone, a new bone is developing, encasing them. So that new bone is known as the involucrum. Now if such a sequestrum exists, then we have to treat that sequestrum. So that is, we have to perform sequestrectomy. Sequestrectomy, in which the sequestrum which lies on the surface of the bone can be removed with little effort after the periosteum has been incised and retracted. So if there is a small piece of sequestrum is lying on the surface of the bone, then we can take up the patient for the removal of the sequestrum, that is the sequestrectomy. Here local anesthesia is administered, then the flap, the periosteum, it is elevated, then we can see the area, the sequestrum is removed. But if the sequestrum is encased by the involucrum, then we have to make a window through the involucrum, then we have to reach out to the sequestrum. Then only we will be able to access the sequestrum and will aid in the removal of the dead bone. So in sequestrectomy, a cavity that is exposed almost always contains granulation tissue in which the sequestrum lies. So after removal of this dead bone, the contents are carefully curated out until the healthy bone is exposed to the view. So after removing the piece of this dead bone, then we have to do a thorough debridement and curettage of the area. All this granulation tissue or what pathological tissues are there, we have to curate it out nicely until we face the healthy bone. Now when we see this diagram also, so this shows the procedure of sequestrectomy and curettage. So here the affected bone, first we have to expose the sequestrum, the piece of dead bone that is removed. Then after removing the piece of dead bone, the sequestrum, then we have to remove all the infected matter that is surrounding the sequestrum. Now following this, now the wound that is already clean, that is either packed open or we can close it by placing a drains inside. So another procedure after that sequestrectomy, then we can go for another procedure known as saucerization. So saucerization meaning it is the excision of the margins of the necrotic bone which is overlying a focus of osteomyelitis. So already one area is affected with this osteomyelitis, one focus is there, then surrounding margins we can excise. So excision of the margins of the necrotic bone which is overlying a focus of osteomyelitis is known as saucerization. It is performed when removal of sequestrum leaves a large cavity and to eliminate the dead space to avoid reinfection of the extensive clot. So already there is a jaw osteomyelitis, then sequestrectomy is present. We have taken the patient for a sequestrectomy. We have removed the sequestrum, nicely cleaned the area. We have done the debridement. Then there is a huge or large cavity or a dead space which is remaining in the bone, the jaw. To eliminate such a large cavity, we can do a procedure known as saucerization. That is, it is done in order to eliminate the dead space to avoid reinfection of the extensive clot. So we have to take care of that large hollow cavity. So this is performed with a large round burr so that when the wound is closed, the soft tissues eliminate a dead space. So as you see in the diagram, so the buccal cortex is reduced to the level of the unattached mucosa, producing a saucer-like defect. So when we see this diagram, first we can see the tooth in question and the osteomyelitis. So we have removed the tooth, and that area of the bone, the buccal cortex is also reduced to the level of this alveolar mucosa or the unattached mucosa. So now a saucer-like defect is produced in the jaw. So now there is no more dead space or bony cavity, because when we suture the soft tissues is going to come and nicely lie over this saucer defect which we have created. So by this way there will be no dead space in such a procedure. So we take up this procedure like saucerization when there is a large cavity is remaining after removal of this sequestrum. So this is done in order to eliminate the dead space formation, because in large dead space is there, again bleeding can occur into that area and blood clot can form, extensive blood clot, again leading to an infection. So other procedure includes a decortication. So when we are talking about osteomyelitis, all these procedure needs to be mentioned, and this also to be taken up upon this is also specific to each cases. Like we have to see the case and we have to determine which procedure we have to do in that particular case depending upon the patient condition and also the radiography picture, what is the clinical picture. So we have to see the patient thoroughly, we have to examine it thoroughly, we have to see the radiographic images, then only we have to decide which procedure we have to undergo. Now another procedure is the decortication. Decortication, by the name itself, it is the removal of the cortex of the bone, decortication. So it involves removal of the chronically infected cortex. So since this is a chronic osteomyelitis case, already long time or long duration has passed since the development of the osteomyelitis, so large amount of sequestrum is formed. Now while treating that sequestrum also, maybe we have to remove a large amount of bone along with that infected cortex, either the buccal or the lingual cortex, usually the buccal cortex. So that is the decortication procedure. It can be done when initial conservative treatment has failed. That means in any case if the osteomyelitis is progressing to or is undergoing a long course, a chronic course, then again the cortex or the bone cortex which is surrounding the area can also turn into a non-vital. In these cases we need to remove the cortex also. So full thickness mucoperiosteal flap is reflected buccally and it is extended to the inferior border of the mandible. Involved teeth are removed along with the buccal cortex and the inferior border until the bleeding bone is encountered. So altogether we can summarize the procedure of decortication such that since it is a chronic osteomyelitis, it is running a long course. So along the course of the disease, one of the cortex, most commonly the buccal cortex of the bone, the jaw, has also become infected. So in that case we have to remove that cortex also along with the lower border of the mandible. So this procedure is known as the decortication. So here primary closure is achieved and pressure dressing is applied to provide better support of the bone bed with its related vascular soft tissue. And following that, drain or antibiotics are used in situ. So when we take a close look at the diagram, we can see that here again tooth in question is removed. Then also in this diagram the buccal cortex is removed along with the inferior border. So if you can see, if you can appreciate from the first diagram, they are showing it as two lines. So that means along with that infected tooth we are removing the affected cortex of the bone also, affected buccal cortex of the mandible. So that is a decortication. So in saucerization we didn't touch the lower border of the mandible. We have just eliminated the dead space using a round burr. While in decortication we remove the affected cortex, usually the buccal cortex of the mandible along with the part of the inferior border of the mandible. So that is the main difference between saucerization and the decortication. Now moving on to the resection. So this is the procedure which we use when there is an extensive involvement of bone is seen with this jaw osteomyelitis. So in this case the large amount of bone is affected, it is a long course chronic case. So we can choose various techniques like hemimandibulectomy, segmental resection, etc. according to the extent of the bone to be removed. So, resection means again we are removing that part of the bone completely which is affected with this jaw osteomyelitis. So, this can be either a hemimandibulectomy in which half of the mandible itself is removed, or it could be a segmental resection in which one affected part of the segment is only removed, that is along with the inferior border of the mandible. So, that is the resection case in case of extensive osteomyelitis. So, this again we can go for an intraoral procedure or an extraoral procedure for attempting a resection. In intraoral procedure, again incision is given intraorally from the midline to high point towards the ascending ramus. Now, we have to reflect the flap, then section the neurovascular bundle which is exiting at the Mendel foramen, which is the Mendel vessels and the Mendel nerve. Then we can use either rotary or we can use a giggly saw to make the osteotomy. That means we are removing that part of the bone which is affected with this osteomyelitis. Now, whenever we do this, again dead space is there, so we have to take care of the dead space also, and we are closing the area. In that again we have to place a drain also. So, whatever collection inside is there can be drained outside. Otherwise, all these collections again can act as a bed for developing another set of infections. In extraoral resections, again we are removing the part of the bone or segment of the bone, could be a segmental resection or a hemimandibulectomy. The approach is a extraoral approach, that is we are approaching the area through an extraoral incision. Most commonly we will use an incision which is parallel to and 1 centimeter below the angle of the mandible, a submandibular incision, following which layer wise dissection is done, the mandible or the affected bone is exposed, the neurovascular bundle is cut and tied, osteotomies, drills, saw, etc. are used, and the affected or pathologic bone is removed. Following this resection, again we have to keep in mind about the immediate or a delayed reconstruction. So, in this case we can also go for a delayed reconstruction. That means again we have removed in resection, since we are removing a part of the bone, either a segmental resection or a hemimandibulectomy itself. In these cases we have to think about a reconstruction. That is, the patient we can help the patient to perform his other oral functions like mastication or maintaining the facial aesthetics. So, in all these cases we have to think about a reconstruction. This can be either an immediate one or it could be a delayed one. It is advocated to maintain the continuity of the fragments, to prevent pathological fracture and also to prevent deformity. It also provides attachment of the soft tissues. So, by taking up the patient for a reconstruction, again we are helping the patient in the many ways. So, this also depends on the condition of the patient, what is the defense or what is the health status of the patient. So, we have to think about all these things, then only we have to plan for a reconstruction. So, in osteomyelitis there are different treatment methods. We have to treat the tooth in question. If it is an odontogenic infection, then we have to take up the procedure or we have to choose the procedure depending upon the case. It could be simple as removal of the tooth and then curettage or proper excision, nicely cleaning the area, or a debridement, or we have to go for a saucerization, or we have to go for decortication in which inferior border is also removed, or in extensive cases then we have to take up the patient for a resection in which one block or proper segment of the bone itself is removed due to this jaw osteomyelitis, and then we have to plan for a reconstruction. So, this is the main things which have to be discussed in the osteomyelitis. So, first, what is the meaning of the osteomyelitis, what is the definition, then what are the etiologies, the microorganisms involved, what is the pathogenesis of the osteomyelitis, at least in the cases of odontogenic infections, then what is the risk factors which are associated with developing osteomyelitis, what is the classification, in which we have already discussed about the two main branches, which are the suppurative and the non-suppurative osteomyelitis. In suppurative osteomyelitis, which we again had acute, chronic and infantile ones. In non-suppurative osteomyelitis, again we had the sclerosing osteomyelitis, which is a chronic one, again which can be focal or it could be a diffuse one. And again there are different other types of osteomyelitis, which could be an actinomycotic osteomyelitis or some special infective osteomyelitis like a tuberculous osteomyelitis, or it could be due to some other diseases. Then out of this, in the non-suppurative osteomyelitis, the main one or the common one which we have to remember is the Garre's proliferative periostitis or the chronic sclerosing osteomyelitis. And we have to be thorough with what are the radiographic features which are associated with the different types of osteomyelitis. As such osteomyelitis, especially in a chronic osteomyelitis cases, we expect to see the mouth-eaten or the mottled appearance of the jawbone. So, other cases then we can see a cotton wool appearance in, mainly it is in the Paget's disease, otherwise it can also be seen in a chronic sclerosing, localized osteomyelitis also. So condensing osteitis also we have to be thorough with that, and how to differentiate between a condensing osteomyelitis with a benign cementoblastoma. Then in the management part, again we have the pharmacological management as well as the surgical management. In pharmacological management, again amoxicillins or the penicillins are the most ones which are the drug of choice for this such kind of infections, the penicillins, and which can be added along with the other antimicrobial agents, which we have to do a already actively draining pus is there. We can take the sample and send it for a pus culture and the sensitivity in which the microorganism is also identified, along with which pharmacological agent, which drug is adequate or proper for treating such microorganisms. Again we can take up the sequestrum also for a histopathological examination. So we need to be thorough with some terms like sequestrum, involucrum, then other management methods. Thank you, students.